Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show. Today, bringing another really fascinating guest involved in science, technology, health tech that's creating a better tomorrow for many people out there. Today on the show, we have the honor of being joined by Dr. On-Yee Amy Lo, who is assistant scientist at the Marcus Institute for Aging Research, as well as assistant professor of medicine, Harvard Medical School, and Beth Israel Deaconess Medical Center. Dr. Lo is both a physical therapist and a research scientist that ultimately aims to prevent the functional decline and enhance functional independence for older adults with mobility impairments by conducting a range of experimental and translational research. And she has rather broad expertise and experience in physical therapy and biomechanics and neuroimaging and neuromodulation, which we'll be talking about. And Dr. Lo has dedicated her career to enhancing, as mentioned, functional independence, quality of life in older adults, and specific research objectives that she's currently working on is to investigate the really interesting connections between the brain and body that ultimately allow for safe navigation through daily environments, to innovate novel rehabilitation interventions to target the brain-body connections, to preserve and ultimately restore control of mobility, and ultimately implementing these experimental findings in various clinical settings. Dr. Lo has a master's in pathokinesiology from NYU, went on to do her PhD in human physiology at the University of Oregon, and we are very honored to have her with us today. Dr. On-Yee Amy Lo, thank you so much for taking the time to come on the show.
Oh, thank you. Thank you for having me to be here. And then I am honored to share all my work.
Yeah. I'm really looking forward to going into all these topics, many which we have not touched on yet. But Amy, I would like to start off sort of by handing you the floor for a little bit to talk a little bit more about your background. I mean, we know we're going to be talking a lot about aging, but in looking back, say your dissertation, which had to do is visual spatial attention during locomotion. Very interesting work in terms of I learned all about toe obstacle clearance and the importance of the right posterior parietal cortex. And the summary was, it's very important to understand where I'm going, or I'm going to fall down.
Yes.
And that's sort of my takeaways. But take us back to those days, if you would, and a little bit of
Yeah, definitely. First chance as a therapist, I think overall, eventually still wanted to apply all the knowledge to clinical practice. And when I was practicing, I realized that we really don't know much about brain. We probably know about muscle. So that made me to the PhD and then grad school. And then so my PhD specifically is focused on the role of cortical control and, like you said, visual spatial attention during locomotion. So I use obstacle crossing as a model because how we orienting and select our visual information while interacting with the objects while walking is a way to really understand not just using the hand, but really like apply to the daily life environment, how we interact with the environment. So the research have a series of projects. I'm not going to go details for everyone, but the key findings show that the toe obstacle clearance was for the trailing leg was significantly reduced when visual spatial attention was disrupted when you are approaching the obstacle, for example. And interestingly, when you direct the attention and to different timing, different phases will actually have different, like you may increase the toe clearance, for example. But anyway, this result highlight how the timing and orientation of attention can affect mobility and definitely help us to understand why older adults at greater risk of tripping and falling. So I further examined some of the brain role, like the role of posterior parietal cortex, PPC, which is a brain region involved in orienting the visual attention. By modulating the activity in the PPC, the posterior parietal cortex area, with a non-invasive brain stimulation we can talk about later, we were able to alter this type of toe clearance and the way the individual interact with their environment when they are walking. So basically, everything related to this type of area is what I've been doing back in the PhD life.
Mm-hmm, mm-hmm. And, it's quite interesting because, in addition to your interest to sort of this intersection between the brain to gait to cognition, ultimately, as we talk about older adults, you also spend a lot of time, studying and publishing on the underlying brain networks that are behind a lot of this. And I found it quite interesting, looking at some of these papers of yours, things like speed and variability of gait. You talk about entirely different functional brain networks. You did this really interesting one about, because this is such a hot topic nowadays in terms of driving and texting, but just talking about how texting on your phone and sort of those activities in the brain, totally different area to, again, the balance of my gait. If I'm texting and walking, things can go wrong. Talk a little bit about some of what you learned during this period in terms of these brain networks. I think it's very important once we get into the transcranial work and all that,
Yes.
of how complex things really are.
Yes,
In this
totally. Yeah. Even though like I use obstacle crossing and then young people, but really we want to see the clinical translational component out of those type of work. And so overall, like there's a complex interplay among the brain function, gait, and cognition. So I think the first few years, over the past few years, I identified a compelling model. One thing is I also look into gait, have different type of component, like you say, gait speed and gait variability, which is a speed we probably very familiar about how fast the people walk, which is very important clinical indicator for a lot of health-related diseases. And then there's also something very interesting for the gait variability, which is how variable you walk. In fact, because when we walk each step to step, it's not the same. We're not a robot like the same timing, but with fluctuation over time. So that can also give you some of the reflect how stable one walk. So first, the one that you mentioned, the gait speed and gait variability, I noticed that this type of different gait components are related to different brain networks. So speed is related to a lot of executive frontal parietal control network, and then variability is related to a very interesting like network between dorsal attention and default network. So I think I will, and then I have a series of work really looking at this gait variability and then the brain network. So and then this compelling model I found is a gait variety. Again, this is a natural fluctuation in walking patterns that reflect how stable one walks. With sustained attention, think about the fluctuation it's a cognitive ability to remain focused and consistent performance over time. So this type of fluctuation for the walking performance and cognitive performance are all related. And then these two type of physical, even though gait and then cognitive like fluctuation performance are also associated with the dynamic interaction between two key brain networks, which is the dorsal attention network and the default mode network. So let's step back and see what this network means.
Sure.
So these two networks, dorsal attention network and default network, operate usually in the opposition. For example, the dorsal attention network becomes active when we are focusing on the external tasks like paying attention. That's why dorsal attention network. While the default mode network is active when you are mind wandering and more like the internal thought. So when you are listening this podcast, hopefully now, actively right now, your attention network is more like engaging. And at the same time, your default network, you may suppress your default network a little bit. So these four, conversely, when you are mind wandering, they may not paying that much attention. So your default network is activate and you suppress your attention network. So imagine how well the dorsal attention network and default network like play together can indicate how well your brain works. So interestingly, the degree of this fluctuation, how effectively one suppress the default network while engaging the attention network and vice versa, is linked to gait variability, how stable, how consistently that you walk step by step, as well as the sustained attention, which is how stable or how consistently that you are able to focus a cognitive task. So I think this is I found this really interesting model to really a good way to look into the relationship between gait, attention, like cognition, as well as the brain. So that has been my main work over the past few years.
Mm-hmm. Mm-hmm. And you mentioned during this is in your dissertation, you you applied transcranial direct current stimulation in studying sort of the dynamics of the posterior parietal cortex. I came across this paper when you were at NYU, using this technology on other sort of hand-object interactions. It's interesting because here we are in 2025, and all things we hear about sort of neurotechnology or about implants, sort of more drastic, let's say, approaches to neurotechnology in the brain. But TDCS, as it's known for short, is a non-invasive tool that has been around for decades now that does all sorts of things. We'll get into some of the papers and some of what you were investigating in terms of sort of older age pathology and so forth. But can you take a little time to just introduce us to the technology of transcranial direct current stimulation, a little its history, and a little bit about sort of what we know about this kind of important non-invasive tool that has the ability to impact many areas of the brain.
Yeah,
And then we'll go further.
Sounds good. So yeah, now we know like brain contribute for a lot. It's not really just a black box when I was first entered to the field. So we know more about brain, but now really the question is whether we can really modulate the brain, change the brain. And of course we can do surgery, open surgery, like do like the more invasive one, but the non-invasive way that we can approach is a tool that we use to modulate this brain activity. Like what Ira was saying, the transcranial direct current stimulation is a type of a non-invasive tool that provide a very mild electrical current to the scalp to modulate membrane potential in your brain. Or put it this way, I like to say like gently like tune your brain. So kind of like you can adjusting the volume of and fine tuning of a radio signal, and you can do this type of fine tuning of your brain. You may not have like huge like activation when you stimulate, may like move your hand, but you're able to fine tune your membrane potential to make it easily to like change your brain behavior. Boost your brain function, for example. And the good thing about this is like it's relatively safe compared to a lot of invasive way. And then, so I think I have done this in a lot of older adults, including several like 90 years old, 100 years old. Most of them are actually 80 years old, and most of them are able to tolerate this type of brain stimulation with the just the feeling or tingling and without any very very dangerous or serious side effects. And so we can not only like safe, I think the first like component is safe. And then TDC is definitely like can provide this type of safe, relatively safe approach. And also we are able to use the modeling to use computer modeling to target, specifically select where we want to stimulate. And that way, then we are able to understand like mechanism as well as provide intervention.
Mm-hmm. And continuing along that, because the applications again are quite broad in terms of neurologic conditions, psychiatric, cognitive, and again all things sort of membrane potential, sort of this whole area of the electroceutical and so forth that have become kind of hot in recent years. So it's an exciting area. Again, looking at some of what you've published in this area, and then we'll get to some sort of the newer papers, but you've looked at things like cerebral microvascular disease, things like resting state brain networks in older adults, and how the complexity can be changed. Interesting things with regard to sensation in the feet. Really a broad range. give us a sort of a little bit of what you learned
Yeah.
across the board here in terms of the potential of the technology like this and some of its applications, because again, quite a diverse set
Yeah.
of sort of clinical dynamics you've been involved in.
Yeah, exactly. So the one way that to think about is like this is a non-invasive way that allow us to, so two way, like one is a scientific way to look in, because to advantage of non-invasive brain stimulation is allow us to examine the causal relationship.
Right.
So like the PhD word role, the different brain area relate to different type of function instead of that means we can see how changing the activity in one brain area directly affects the behavior rather than simply the correlation. So the approach one way is I help us understand the underlying mechanism and develop the targeted intervention. In terms of interventions, and our team, like you said, apply TDCS to target different brain area to enhance like physical and cognitive functions in older adults, like the different cerebral microvascular disease or other type of Parkinson's or older adults at high risk of fall. So I think there's a lot of outcome, but our main findings or like main area that our team has been focused on is to stimulate the area called the left dorsal lateral prefrontal cortex. So we have shown that in different young, older, and older adults with functional limitation, we have done a serious work and targeted this area. We know that that can improve the dual task walking performance. That is the ability to walk and then talk simultaneously, like you said, like walking and tasking. It's an example of dual tasking, which is very interesting because dual task performance is a key indicator for fall risk and cognitive impairments.
Mm-hmm.
So our team have found that some main high-level things, this area seems to be very important for this and then walking dual task performance and in different type of population. And we have done started with like just lab one, and then we have done like just finished a whole 5-year R1 project for multiple stimulation session, like up to like 1 month. We have like 2 weeks stimulation, like now we have 1 month, and now we even trying to like stimulate it at their home to do some of the remote stimulation. So we have a serious work that target this area and then seems to be promising for a lot of fit functions. And then what we have learned is there's also a lot of variation among them. So over the years, I think technical improve. So now we are able to target better with a more personalized approach. If we are able to really target the area that we hope to target with the really high dose or enough sufficient dose, I think we will have a better effect. So yeah, a lot of things that we learned because like in the past is like spongy, so we are not able to be too specific. Now we are able to be more specific and we can start to have some personalization out of it. But yeah, this seems to be a promising way for future to apply to the older adults because it's safe, relatively safe, and then you can relatively target the question and without the side effect from the pharmaceutical effects.
Yeah, it's very one thing I did not mention. I did not mention that one of the papers is entitled "Non-Invasive Brain Stimulation to Reduce Falls in Older Adults," and I was wondering if you could. I mean, this is something that again we probably don't talk as much as we should, but this number alone in terms of the injury cost for falling in older adults is something like 50-60 billion dollars a year alone, and then we don't even think of the amount of death that occurs within, I think it appears like within like a year after that fall is strikingly high. Could you just say a couple words about that? Because I know we're going to be getting into how you're using this technology to stimulate new physical activity in folks that aren't as active. But I was wondering if you could just say a couple words about this because it is an important figure that we don't maybe talk enough. And I wonder if you could just say a couple words about it.
Yes, totally. I feel like fall and then dementia. I think these two are the two main concern for older adults, I would say. And then interesting, fall is actually have so many components, including cognitive component that can cause fall. Just like people with dementia have double the chance of fall compared to those without the cognitive impairments. So looking at fall, I think of course we need to be like strengthening exercise and everything, make sure our muscle and balance and then everything's like hardware sort of in a good shape. So I highly encourage everyone to exercise and all the type of thing to make sure we have a strong muscle, strong bone. So when we fall, you won't easily get fracture and then stuff like that. But another component people are less like focused or think about, they don't think about brain is actually also contributing to fall. So that's why I think over the years, I understand more and then really trying to emphasize that older adults is a lot of issues, not just muscle, not like young people. They may have take a lot of things for granted. They can walk and maybe talk at the same time easily. They can continue walk. But if you notice older adults, when they walk and talk, they have to stop their walking.
Yeah.
A lot of time they cannot walk and talk. That's just not a very like active daily example to show that a lot of things like declining in older adults, and then it's not just the physical part, it's cognitive part. So when we're doing the intervention for falls, for example, it's not just think about the peripheral component, but the central cognitive brain component should
Yeah.
also be considered. So that's why I think having a tool that can combine with the physical exercise or like muscle strengthening, and then all type of peripheral approach together will provide a very promising future for the intervention in falls and a lot of problem in older adults.
Excellent. Excellent.
Mm-hmm.
Well, this then takes us to the very recent paper. So this was just a couple weeks ago, Journals of Gerontology, June 2025, entitled Modulating Brain Activity to Improve Goal-Directed Physical Activity in Older Adults. And again, you basically studied coaching or sort of the general behavioral counseling. Hey, it's important for you to get up and exercise because this will help you not fall and live longer and so forth. But combining that with TDCS, very interesting paper. And I'll just sit back and ask you to walk us through what you learned here. This was I think a 12-week study and randomized controlled trial, but very interesting body of work. Please take your time with this one.
Yeah, I think definitely along with what we have been talking about, like older adults issue is not just one or the other. It's really a lot of component. So one way we know like brain stimulation can potentially help us to improve our brain function. And then I think the most like uh everyone know exercise or being physically active is important. And then there's a ton of research that strongly suggests we need to be more physically active and do more exercise. I don't think there's I think we have a lot of study about this type of area. I think the main challenge is most of the older adults still not active, not being physically active. They still don't do enough exercise. And one of the barrier, like I said, like can be like a lot of like muscle pain type of issue, but I think all the factor related to some of the brain function, like lack of motivation, and then or they know this concept, but they have the hard time executing this idea, like executive function. So for this particular project, I'm trying to like see whether we are able to combine the intervention, because what we have known is the coaching seems to work. So for example, you set up a very specific goal, you give them a clear goal, like what goal that you want to accomplish, and then you identify certain barriers. What kind of barrier limit you to become more active? We talk about this, discuss about this, as well as come up with some solution and strategy to overcome those barriers. So people have been doing this type of behavior approach to improve physical activity. But I think, as you know, like we know about this a lot of time, like people still don't do it, or they stop doing this type of regulation after the intervention ends. Therefore, the reason I talk against, but because potentially our brain also needs some help. So especially in older adults. So this study, we combine behavior intervention for two arms. Everyone have this type of behavior. So everyone will receive coaching like every 2 weeks for 2 months for us to understand, like set up a goal. And then so for the goal, interesting is I provide everyone a Fitbit. So everyone can have a goal that can objective goal. They are able to see their performance in the daily basis. So first, of course, they have baseline, they without any intervention. So we are able to start with some of the baseline performance and then look at how many steps they have for their baseline goal, and then we start the intervention. Everyone will have this type of behavior, like, okay, this is how you walk for the past 2 weeks. Is there we can like increase to a certain step and what kind of barrier, and then some strategy we can do. But the difference between these two arms is one, they receive a real brain stimulation, which is the TDCS, target the executive function left DLPFC for 2 weeks for 10 sessions. And the other arms also have it, but it's a placebo, it's a sham. So both of the arms, one is the real stimulation, one is the sham stimulation. And we want to see like the same like 2 months, but the first 2 weeks are the stimulation. After these 2 months, how will they improve after the intervention? So what we found is everyone, like on average, not everyone, but on average, everyone improve for both arms, because I think the behavior does work. I really people like able to like, and then remember this population are relatively frail. They are like about close to 80 years old, and they are definitely very inactive, and they live in subsidized housing. So there are a lot of like risk factors for them to not being active already to start with. So their baseline is quite low. And then the sham group, they already on average every day they improve like at least like 500 steps. But the other group improve double, like at least like 1,000 steps in the daily basis, like throughout. Especially, I think another part is not only the real double the steps counts, but they also continuously improve, because we, after the intervention, we don't provide any interaction, but we still track their performance in the 3 more months. They continuously improve, even we don't have any intervention, which is very interesting because a lot of intervention will disappear after intervention's gone. So the main finding is a real group seems to improve, significantly improve than the sham group, and then they also continues for up to 3 months.
Excellent.
Yeah.
Yeah, it's again a very interesting set of work, and again, continuing on this theme that you've championed in terms of the connection between the brain and cognition and these interesting tools. At the same time, you are involved in a whole other body of related work that has to do with what I'll broadly sort of define as AgeTech. And some of these more sophisticated wearables, and ultimately how, because we're in this era of aging in place, of health in the home and all of that. And again, you have several publications on interesting smartphone apps in terms of measuring gait speed and other tools. Would love for you to just take us into some of what you're doing sort of in this part of your portfolio, and sort of maybe where you see a lot of this going, because I know we're along with the smartphone apps and all the wearables, there's now all these things that look like kind of like these headphones, which supposedly do something. I'm not exactly sure what, but what's real, what probably has a few years to go, but in terms of when can I be put my headphone on a couple of years from now and get my stimulation and, and X, Y, and Z.
Yeah, that's definitely a lot
Or not.
going on. Yeah, so definitely because I study like Gait, like walking Gait, a lot of time like the study is implemented in the lab setting or like clinical setting. I think everyone sort of agree like your performance at home is probably like different than your performance in the lab or when you're in the clinic.
Sure.
So really, and then like I said, I'm really interested in translational work. So another line of work is that in addition to observe their performance, like Gait performance in the lab or clinical setting, how can we also look at their performance outside of the lab and in their home or in remotely in other places? Plus, like all the other benefit you can do remotely, not because of like COVID, but people don't have to travel a lot. So remote intervention or remote assessment is also a line of work that I'm really interested in. Like not only like the brain simulation we can do remotely, but also assessment part, which is get to the point that I also have a line of work that we develop a smartphone app that we are able to use the sensors in everyone's like smartphone, because we have very quite good quality IMU in your smartphone. We are able to capture your performance, including like gait and then even like balance when you are using your phone. So we use this IMU signal information. We are able to identify the gait events like health stride time, and then we are able to capture your gait events. And through that, just one MU, even put into the pockets, we have already validated with the lab like gold standard equipment. Even within this IMU in your phone, put it in your pockets, no matter how tight your pocket is, we are still able to look at this type of fluctuation when you are walking. So we developed this Gait app, and we are able to capture the walking both during like normal walking as well as walking and counting backward, like the dual task condition, which is the main focus in our team. That both normal walking and dual task, we are able to capture this gait performance when you are doing this remotely at home. And then we found that a lot of older adults are able to do it and then provide really valid and reliable like findings, including those who have mild cognitive impairments. Many of them are also able to do it. So we also try on like several, we also work with the people, older clinician with the cancer treatment, which is also another population that we see very important, because people receiving cancer, they like a lot of work, they have to travel, but then we are able to also have a work with our collaborator to try to apply this in the older adult with cancer population. So we started to like continue to improve this formula, to the algorithm, but also trying to apply to various clinical application.
Yeah, it's very interesting because I saw that paper in there that it was a couple months ago that you did with the blood cancer work and this. And at first I was like, I was like, oh, that's a little different. But then when I'm thinking personal experience with loved ones that had blood cancer, and it wasn't as much the blood cancer per se at the end. As things got worse, it turned into, as you were mentioning, the cognitive issues, the gait, the wasting, and all of that. And I found that quite interesting. How you're bridging, both worlds there with that particular cancer study. So that was quite interesting as well. So thanks for doing that work, and that's in the journal Geriatric Oncology. I mean, what else is coming up? I mean, again, you have a very, really interesting portfolio. I saw, you're one of the winners of the Healthy Longevity Challenge a couple of years ago. I think that's where I first actually read about you. What's coming up for 2025 as we get in 26? Other initiatives that I did not touch on that you want to mention? Conferences, talks that are coming up. Anything else that you want to mention while we have you today, please?
Yeah, well, that's several lines. So we can continue with the Gait app, like walking is one way, but also we are developed app, continue the app that it's called SPPB, because I know like clinically a lot of people like it's called short physical performance task. It's a three component: walking, standing, and sit to stand. So walking definitely provides certain important information, but combining standing component, walking, and then sit to stand information, we are able to look into more like comprehensive type of. So we developed this app. This is one line of work that continue with the remote app component. And second line of work I see is the Gait's cognition, and then so I developed a brain stimulation montage, which is targeting the dorsal attention and then default network brain area that we talked about earlier of the podcast, that I am hoping to finish up this project soon, that we have a lot of people like going to this study that they have the MRI, they have the brain stimulation inside the MRI. So I developed this like montage. They go over like stimulation in the MRI, so we can really see this novel montage, whether we can really target the target area we want to target. And then we have some intervention, like short intervention after this like mechanism, and see whether this intervention can really improve or provide some signal to really improve their gait and cognition attention. So this is hopefully like it's almost like finished. Like we have done this for a few years, and then we try to wrap up to hopefully look some promising results for this line of work. I think the stimulation in the MRI is relatively like now new, so we really know what's going on. And then so one is a remote, one is this. And the third line of work is I am also like really actively engaged with the healthy aging initiative.
Okay.
So within the Marcus Hebrew Senior Life, I think there's a lot of older adults like trajectory study that we see older adults how they age, and then we collect the information in the yearly basis. But what has been missing is we don't know much for those who living in the housing of
Okay.
older adults. Most of the study I think we study is like community older adults, and they go through like very comprehensive like examination assessment over a year. So this is not the intervention study, it's really the observation study, but within the housing sites, like study of like healthy aging initiative to really see how older adults age within the in the individual living the housing community housing sites. And we are able to not only capture like a physical, cognitive, like social type of behavior, it's really a lot of culture and social components that actually actively like, affect how people age. So this is a really interesting healthy aging initiative that I'm also like really actively involved, and this will be continue for my research to really know how older adult age. So yeah, that's probably like project wise, and then continue writing a lot of grants. And then in terms of conferences, I just went to ISPGR, which is the conference I usually go, International Society of Posture and Gait. I guess ISPGR.
Okay.
I forgot what R. Posture, Gait,
Research. I don't know.
research, yes. So that's conference. I just came back from that conference, which is really exciting that continue to, because all my work is related to Gait and posture. And then so this is my to-go conference. I had a great time there. And then we will have another like conference by the end of this year, GSA in Boston this year,
Sure.
November. And yeah, so I will probably present some of the work that I talk about today. And yeah, so there's a lot of like ongoing pieces.
Yeah. No, you're definitely busy. You're gonna be busy. I look forward to continuing to follow your work, and the whole, as you're mentioning, the whole issue with the smart home, and then again going back to this aging in place concept, and using it not just for therapy, but to learn more about the aging process is really quite fascinating. So I love these themes. Again, for everybody out there that's going to be listening to this episode of the show across the podcast networks, or who will be watching on the YouTube channel. Again, you've been spending time with Dr. On-Yee Amy Lowe, Assistant Scientist, Marcus Institute for Aging Research, Assistant Professor of Medicine, Harvard Medical School, and Beth Israel Deaconess Medical Center, doing really amazing things at this intersection of physical therapy, of neuromodulation, of gerontology, ultimately to help prevent functional decline and enhance functional independence for older adults. Amy, again, I want to thank you for taking the time out of your schedule today to talk to us for a little while. Thank you for everything you do in your program, and as we like to say on our show, thanks for helping to create a better tomorrow for many people out there via the research you're conducting. Really great story.
Thank you.
Great having you.